Thank you. Good morning, everyone. So in order to address in the best way probably how to break the barriers to oral nutritional supplementation and how to address optimal strategies to address malnutrition, indeed an important issue is the topic of health economics. So I will not stress you with a large list of numbers. I'm a clinical nutrition specialist. I'm doing some research in health economics. So what I want to do with my lecture is to make some spotlights, to provide some spotlights on which could be the important issues to be addressed while dealing with the issue of oral nutritional supplementation. So probably many of us are not familiar with this topic, and what I want to provide is just an insight. So why it is important also this topic, because it's closely related to one of the main barriers in providing good access to nutritional care. This is also the outcome of the recent ONCA conference held in Turin. We spent a lot of time with many specialists all over Europe about the topic of malnutrition and the importance of collecting data in the health economics with health economics studies. Costs are important, and these are also important for increasing the access to nutritional care. And despite we have a large mass of data from health economic studies, we do need to collect more data to convince research allocators that even nutritional care could play an important role in improving the patient outcome. So that's why we are asking why focusing on the health economics. Indeed, the healthcare system are challenged by the high and escalating costs of care. But at the same time, with increasing costs, what we do need to do in our daily practice is to implement practices that are bringing benefits to the patient, but are also cost-effective. And this is what they are looking at, research allocators. They are not dealing with the health of the patient, they are dealing with the cost. And if we can improve the outcome of the patient, improving specifically reducing the costs, we win the challenge. And we can do this in several ways. There are different tools to address the issue of health economics. What we do with health economic study is to evaluate the impact of a medical condition, so the burden for the system, for the patient. But at the same time, we address the costs that are related to the care of this disease, and in particular, now we are focusing on the costs of nutritional care, just to understand which is the benefit compared to the money invested in treating the patient. This is the cost-benefit analysis. But what is even more important is the concept of under, that is to say, malnutrition is under-recognized, malnutrition is underestimated, malnutrition is treated, malnutrition is under-coded. So if we look, for example, to some of the data available in literature, you can see that, for example, in the community, and this is analysis conducted in the US, the cost related to disease-related malnutrition, at least for 8 main diseases, not for all the diseases, so the picture would be even worse, it's associated with an increase of about $500 per resident per year. But if you address another setting, for example, the hospital setting, it has been estimated in 2021 that the cost of managing malnutrition in the hospital setting is approximately $60 billion. This is in the UK. But this is on a ICD-based diagnosis. And the prevalence measured in this study of malnutrition was only 9%. And we know that the picture is even worse. So one of the major problems is the fact that malnutrition is undercoded. So again, we are still underestimating the problem, and only coding malnutrition at discharge can bring money to the hospital. So this is an important issue, because if we talk with our general medicine resource allocators in an hospital setting, and they are also health economists, they are dealing with costs, because hospitals are industries, are producing money. It's not good to tell, but anyway, this is the reality, and only coding malnutrition can bring more gain for the hospital. And this is for the cancer setting, in which probably the issue of malnutrition compared to the problems related to this disease is not so high. So if we split this picture to all the other diseases, the situation probably is even worse. So if we look to a single country, because a major problem in health economics analysis that we are, for example, analyzing prevalence data from one country, but we have estimation of the costs related to malnutrition that has been done in another country, so we are combining the situation in different countries. So if we do a specific analysis in a single country, considering the cost of the single country and the dimension of the problem, and we can see that the picture is up to 50%. In adults, and in old adults is even higher. You can see that we are talking about billion euros in terms of money spent due to the increase in the length of stay, and money spent in, for example, readmission to hospital that can be prevented by appropriate nutritional care. Even more important, the cost that we had looked at are mainly related to treating the morbidity and not in the money invested, not depending on the money invested for treating malnutrition, approximately 5%. It is to say that most of the costs are not related to nutritional intervention. So something that can be implemented in a very cost-effective way. And this is a picture only for direct costs, that is to say mortality, length of hospital stay, institutionalization, nutritional support, something that we can measure easily. But there are also hidden costs, the indirect costs, for example, those related to insurance costs, loss of productivity. These are something that are not easy to estimate and not easy to count in all the budget, but even play a role. But we are dealing with the issue of oral nutritional supplementation. So if we have to address the cost-benefit analysis, a key issue is the fact that our intervention is taken by the patient. This is a big issue because nutrition is not taking a pill. And we have already listened from the brilliant previous lecture that there are so many problems related to food intake, so many problems that need to be faced in daily practice. The problem of appetite, the problem of providing to patients high energy density meals. So that's why the use of oral nutritional supplements, because we are considering cost-benefit analysis of oral nutritional supplements. Oral nutritional supplements could be an effective intervention in increasing the energy intake, the protein intake of our patient compared to standard nutritional counseling, particularly if we are relying on the use of energy-dense formulations. So those that have an energy content higher than 2 kilocalories per ml. Because every sip counts in daily practice. And sometimes the problem of compliance is one of the most important that we need to face. Sometimes we have to adjust the taste of our nutritional supplements. Sometimes we have to adjust the energy density, the texture. So we do need an effective strategy. And oral nutritional supplements are an effective strategy, particularly if we stress even more the recommended target for energy and protein intake in this patient population. If we look at the recommended target and what we can do in daily practice, really, there is no discussion reasonably. There is a big rationale of providing oral nutritional supplements. Because, for example, if we address the low protein intake in the community setting, that is to say, a really uncomplicated setting, and we rely only on dietary advice, you can see that over time, over 3-6 months, only half of the patients are able to reach the recommended target of 1.2, which is for the general population, and which is even higher, for example, during acute or chronic conditions. So dietary advices alone frequently are not enough, and we need to invest money in effective strategies. Oral nutritional supplements could be a solution. So we do need to evaluate their impact also in terms of costs. And cost-benefits analyses are useful in this way because we are addressing the cost of an intervention, which are expressed not only in terms of health outcomes, but also in terms of costs. And with this analysis, we can also compare different interventions. That is to say, for example, nutritional counseling alone compared to those combined with systematic provision of oral nutritional supplements. In this way, probably cost-effectiveness analyses are a siding partner to have more convincing data, because in this way we can really compare two interventions related to the outcome of the patient. But the outcome sometimes is only one or two. The overall benefit should be perceived over several health outcomes, quality of life, and not only the rate of infection, mortality, length of stay, and so on. We have different studies to address the issue of health economics, particularly the cost-benefit analysis. These are randomized trials, but even more important, real-world evidence study and quality improvement program. Indeed, they are different studies because they have strengths but also have limitations. And these are related to many issues: the perspective that we are addressing, the risk of selection bias, the sample size, the costs, the outcomes that we can evaluate, the compliance, so adherence to treatment. For example, in a randomized trial, the adherence is reasonably higher compared to daily practice because we are pushing quite a lot on having the patient complying to our intervention. But the major problem is that we are selecting, for example, a specific population, a specific disease condition with some inclusion and exclusion criteria. So we are restricting the picture on a specific set of patients. And at the same time, we are losing some generalizability of our results. That's why probably real-world evidence that provide more rough data are probably more useful to convince research allocators because we are covering a large number of diseases, we are covering a more heterogeneous population, and we can rely on the use of pre-existing data, we can improve the collection with additional ones. So we have more generalizable data that can enable to improve access to nutritional care. And there is a strong evidence. We have now several studies and several meta-analyses. These are usually addressing randomized clinical trials, so with the limitation that we have just talked about. But all these studies, most of these studies agree that there is a cost-benefit, positive cost-benefit perspective in using oral nutritional supplements. This applies to the hospital setting, for example, the surgical setting, in which we can reduce the rate of mortality, the rate of infections. Most of our complications are related to infections related to malnutrition. We can reduce the length of hospital stay. If we consider that 1 day is about 800 euros, you can see that for every patient that we are reducing 2 days, the length of stay, we are saving 1,600 euros. But there are also costs related to other complications, indirect costs of malnutrition. And good evidence is available also for the community and the home care setting. We have meta-analyses that demonstrate that we have a reduction of the number of hospitalizations. We cannot reduce mortality, but we can reduce the costs related to unexpected or unintended hospitalization. We can improve quality of life, the rate of infection, the reduction of postoperative complications, faults, functional limitations. But we have to consider that most of the evidence is related for short-term intervention. The major problem of long-term intervention is the compliance. So we do need to implement effective strategies in the short term that enable to improve the outcome and are also cost beneficial for the patient. So just to summarize with some take-home messages, indeed the nutritional care brings value to healthcare. We can improve the quality of our care and we can improve the outcome. But indeed, these data must be used to increase the access to nutritional care. This is a major barrier. I'm a nutrition specialist, and in daily practice, what I'm used to stress is the fact that I am a prescriptor, and I do need to see the patient. And this is to say that the patient must be referred to a nutrition specialist. This is also a barrier to improve access to nutritional care, because if we don't see the patient, we cannot prescribe, we cannot get benefit from nutritional care. And we do need to build up a multidisciplinary team into the hospital, or create at least a management flow for specific disease settings and putatively to all the patients that can get benefits, being malnourished, being old adults, and being underestimated and undertreated. But policies should be implemented for the reduction of direct cost and indirect cost too, that unfortunately now are still underestimated. That is to say that we do need more studies in this setting. The problem is still the same. Malnutrition is underestimated, malnutrition is undercoded, the cost of malnutrition are underestimated, the patient malnourished are undertreated. And we do need more data to increase access to nutritional care. And in this way, also health economics can be of help, because stressing resource allocator, we can do more for improving the system. Thank you. Yeah.